Dear colleagues, Marcus at Home welcomes Professor Beck da Silva in Porto Alegre in Brazil and Professor Juan Carlos Trullàs in Olot, with whom we would like to discuss the use of thiazides in decompensated heart failure based upon their two randomized controlled trials that were published in the last 2 years. Dear Dr. Trullàs, we are very happy to welcome you for the first time at Marcus at Home. And dear Dr. Beck da Silva, welcome back after 2 earlier discussions with Marcus Säemann or with myself.
Thank you.
Thank you very much. Very big pleasure.
Dr. Juan Carlos Trullàs is an internal medicine specialist at Hospital de Olot in Catalonia, and he's professor at the University of Big Central University of Catalonia. He is the principal investigator of the CLOROTIC trial. Dr. Luis Beck da Silva is cardiologist and professor of medicine at the Federal University of Rio Grande do Sul, and he conducted a randomized controlled trial on thiazide diuretics that has been published in 2021. This discussion follows a talk on the use of diuretics in heart failure with congestion from last autumn, when we were honored to meet Professor Mullins, and we invite all colleagues interested in a tour d'horizon to watch that video before or after today's talk. And with this, I'll leave the microphone to my co-moderator, Professor Marcus Säemann from Vienna.
Yeah, thank you that you have come to this event. As you know, we are specialized or dedicated to cardiorenal medicine, and you have achieved a lot of insight, and we are happy now that you share us your trial, your study results, the rationale why you did this trial, and were the conclusions that we can draw now, also from a practical point of view.
Okay, first of all, thank you very much for your kind invitation, for being here in this Marcus at Home session. I know that you are all aware of this background, but I think it's important to see the context of this topic. And the combination diuretic therapy is a field with very few prospective trials, as you know, and most of the recommendations on guidelines and expert papers are based mainly on their opinion. And you know as well that when patients are chronically exposed to loop diuretics, they can become resistant to these diuretics. Some of them because distal parts of the nephron can increase their avidity to sodium, and then these patients then persist with fluid overload despite you increase the doses of loop diuretics. And one possible approach to overcome this situation is the addition second class of diuretics. In this case, this evening, we're going to talk about thiazides. But until recently, this kind of approach was rarely subjected to large-scale clinical trials. And that's the reason why the experts still recommend to first intensificate the doses of loop diuretics before adding a second diuretic agent. So in this context, we designed this trial, the CLOROTIC trial, which was an independent, randomized, double-blind, placebo-controlled trial that we performed at 26 sites in Spain. We recruited 230 patients diagnosed of chronic heart failure that despite being treated with at least 80 milligrams of furosemide, they had to be admitted due to an acute decompensation. And during the first 24 hours of hospital admission, patients were randomized to receive hydrochlorothiazide or placebo during 5 days of treatment. And the dosification of the thiazide diuretic was stratified according to the baseline glomerular filtration rate, as you can see in the slide. In addition, investigation had an algorithm for furosemide dosification in order to be as homogeneous as possible in both treatment arms and between different treatment sites. These are the endpoints of the trial. Primary endpoints included changes in body weight and patient assessment of dyspnea in the first 72 hours after randomization. As secondary endpoints, we assessed the same primary endpoints, change in body weight and patient dyspnea assessment at 96 hours. And in addition, we assessed mortality, re-hospitalizations at 90 days after hospital discharge, and very important, the metrics of diuretic response. Finally, the safety endpoints included changes in renal function and changes in sodium or potassium anytime during the hospital admission and during the randomization treatment. These are the main inclusion-exclusion criteria. It's important to highlight that patients had to be diagnosed of previous chronic heart failure. The patients with de novo acute heart failure were not allowed, and they had to be admitted for the compensation despite being treated with at least 80 milligrams of furosemide or equivalent doses of other loop diuretics. And in the red square, you can see the main exclusion criteria. Patient had to be stable. Severe or symptomatic hyponatremia was an exclusion criteria. Patients could not receive any type of thiazide diuretic during the month before randomization. And I think it's important to highlight that renal failure was not an exclusion criteria. That means that any value of glomerular filtration rate upon randomization was allowed, with the only exception that patients require any renal replacement therapy technique. These are the main baseline characteristics of patients. You can see that we included patients with advanced age. The median age was 83. Almost 50% were women. And most patients had a high burden of comorbidities, including obesity, hypertension, diabetes, atrial fibrillation, etc. More than 50% were in class 3 of the New York Heart Association functional class. The median ejection fraction was 55%, and more than 2/3 of patients had HFpEF. And the median glomerular filtration rate on randomization was 43 milliliters per minute. Both treatment arms had high levels of natriuretic peptides, and more than 50% were treated with renin-angiotensin-sifting inhibitors or beta blockers. And also 1/3 were treated with MRA, but at low non-diuretic doses of 25 milligrams per day. So let's see the primary endpoints. As co-primary endpoints, we assessed changes in weight and dyspnea assessment. And those patients that were assigned to combined diuretic treatment experience more lost weight than those assigned to placebo, and these results were statistically significant. But we did not observe a significant change in the dyspnea assessment by patients at 72 hours. When we assessed the same endpoints at 96 hours, we obtained very similar results. That means that patients assigned to the thiazide diuretic experience more weight loss than those assigned to placebo. But we did not observe a significant change in the dyspnea assessment, neither at 72 or 96 hours, neither using a VAS scale or a Likert 7 scale. According to the metrics of diuretic response, again, patients that were assigned to the active treatment with 2 diuretics had better results in terms of 24-hour diuresis and weight loss per milligrams of furosemide, both at 72 and 96 hours after randomization. In addition, patients with double diuretic treatment experienced more diuresis adjusted for milligram of furosemide, but in this case, the results were not statistically significant. There were also no differences in the length of hospital stay. We believe that this is probably because, for safety concerns, per protocol, it was mandatory to remain admitted during the 5-day of randomized treatment because of safety concerns during this period of the study. And we did not observe significant differences in all-cause mortality or rehospitalizations, neither at 30 or 90 days after hospital discharge, as you can also graphically see in these Kaplan-Meier survival curves. In the paper, you can also read that we did a combined endpoint, including both endpoints, mortality or hospitalization, and also a competitive risk analysis. And in none of these analyses, we observed that the double diuretic therapy was associated with a worse prognosis. According to safety, in this case, patients that were assigned to hydrochlorothiazide had a higher proportion of worsening renal failure. But the definition of worsening renal failure, this is written in red. It means that patient had to increase at least 0.3 milligrams per deciliter of creatinine values, or a decrease in glomerular filtration rate of at least 50%. When we analyzed electrolyte disturbances, there were no differences in the proportion of patients that experience hyponatremia, neither using these cutoff points, 125 and 130. And there were no differences in severe hypopotasemia when using this predefined cutoff of 2.5. But when we did another analysis, a post-hoc analysis using a higher cutoff of 3.0, in this case, the proportion of hypokalemia was really higher in the patients assigned to thiazide treatment. According to the adverse events, there were no differences in the proportion of serious adverse events reported by the investigations during the whole trial duration. And it's important also to highlight that there were no cases of hypomagnesemia. We did an assessment of magnesium at inclusion and at the hospital discharge, and there were no cases of no problems with this electrolyte. And there were also no symptomatic cases of hypotension reported by investigators. And also asymptomatic hypotension was similar in both treatment arms. This was not pre-specified in the protocol, but we also perform a congestion analysis as a post-hoc analysis. And we observe in the red, in the orange bars, that patients that receive double diuretic treatment had better results in terms of edema, pleural effusion, and also ascites. And finally, I think it's important to highlight these important results. This is just a summary of the main subgroup analysis, but in the supplemental files of the paper, you can have a look at the complete sub-analysis that we perform. But it's important to highlight that the effect of treatment was consistent in all these subgroup analyses that we perform, no matter the age, heart failure etiology, ejection fraction, kidney function, or the dose, the baseline dose of diuretic treatment at home. So as you know, the paper is published in the European Heart Journal, and we are very happy to say that it was chosen one of the 10 top papers of heart failure in the year 2022. We're very happy for that. And as a conclusion, a very brief conclusion of the trial, I like to say that this is an independent clinical trial. We did it with a really very low budget, but we think that with a high quality as well. And we think that it's a very welcome data that adds important information to a field with very limited evidence to date in this field of combined diuretic therapy in acute heart failure. We think that we have shown that the use of oral hydrochlorothiazide is a very inexpensive strategy. It's safe and it's modestly effective on top of loop diuretics in patients with acute heart failure. I think that we will like to know that we are performing post-hoc analysis, trying to assess if these results are consistent in the whole spectrum of glomerular filtration rate in the trial. As I said before, the median glomerular filtration rate was 43, but the range was very wide. Patients from 14 to 109 of values of glomerular filtration rate, and only 23% of patients had filtration rate above 60, and the rest had also important limitation in this point. So last week we sent an abstract to the forthcoming Heart HFA Congress in Prague. So we're looking forward to present the results if they are accepted for presentation in the next month. So I always like to finish the presentations of this trial saying that this has been a very huge teamwork, and this is part of the team, and I always like to give thanks to all the investigators that are participating in the trial, and I'm always free to answer additional questions, and I leave you my Twitter account and also my email account if it's necessary. And that's all I wanted to share with all of you. Thank you very much.
Congratulations from our side. We know this is an extremely hard work to do with so many centers and so many sick patients. I mean, the median GFR was 43, so these are really sick patients in so many centers. So congratulations from our side. But we will go ahead now with Professor da Silva, right?
Okay. So thank you very much for this opportunity again. It's quite an honor to be able to present my work for you, and hopefully we can have a very fruitful discussion afterwards. So this is about the effect of thiazides in patients with acute heart failure, a randomized clinical trial. I have no conflict of interest with this presentation. So in the background, you all know about it, but I'll highlight that mostly patients, especially older than 65, they present, majority of them, with congestion to the emergency room. And it's nice to know that in the dose trial, there was an increase in the use of thiazides by 11% in patients who are using low-dose loop diuretics, showing us that there was already a trend of our colleagues to associate thiazides to loop diuretics in patients with acute decompensated heart failure. And before our study was performed, less than 400 patients have been included in clinical studies, mostly observational, assessing the combination of diuretics in patients with acute decompensated heart failure. And the use of hydrochlorothiazide may increase the response of loop diuretics. However, this has not been formally tested before our study. It's also important to note the congestion, the prognosis aspects of congestion. This is a study that we have also performed in the past. We have shown that patients who remain congested, that means with a clinical score higher, they had a lower event-free survival over 6 months period, showing that before or beyond the symptoms, congestion may also have a prognostic impact. So the objective of our study was to evaluate the effect of adding hydrochlorothiazide 50 milligrams to furosemide on congestion and symptoms in patients with acute decompensated heart failure. So the trial design of our study was a randomized, single-center, parallel, double-blind, placebo-controlled academic clinical trial. We have no industry support whatsoever. So the patients were selected and then enrolled in the study, randomized either to hydrochlorothiazide 50 milligrams a day. There was no differences like CLOROTIC trial in doses. All patients received 50 milligrams for 3 days beyond IV furosemide, and the other group received placebo for 3 days in the same doses and shape pills. The patients were followed for 3 days and are discharged, whatever happened first. This is our diagram showing that we have screened 312 patients in order to have a randomization of 26 for hydrochlorothiazide group and 25 patients for placebo group. The patients who were discharged before 24 hours were not considered for the final analysis. So we ended up with 25 patients in one group and 22 patients in the placebo group. Our demographics, basically our key inclusion criteria were patients with EF below 45% and GFR larger than 30 were excluded, included. Below 30 was excluded. And it's important to note in our table 1 is that we have a population of heart failure patients with ejection fraction around 30%, which is quite different from CLOROTIC trial. We're gonna talk later. So our primary endpoint results is weight change per day. And we can see in this slide that we have seen an increased weight loss of 0.7 kilos per day. And this was marginally statistically significant. When we performed the secondary analysis looking at weight change for each 40 milligrams of furosemide that patients have received, we have seen a 0.4 increased weight loss for each 40 milligrams of furosemide, and this result was statistically significant. The secondary outcomes and safety profile was assessed as well, and we can say that there was a change in creatinine, a very slight change toward increased creatinine in the thiazide group. But when we did stratification with a cutoff of 0.3 milligrams per deciliter, we could not see any significant increase in creatinine in our patients. So that being said, we may say that there was no major clinically relevant safety concerns. There was no change in potassium, no change in sodium levels as well as no significant change in mortality. This is a provocative slide showing in another study called the Valenti et al. Study, showing the prognostic or the diuretic response and the prognostic of patients based on the diuretic response. So that means that patients who respond better, they will go better, and patients who do not respond will have a worse prognosis. And when we plot our result on this graphic, we can see that our patients went toward a better diuretic response, which is a provocative thought that maybe thiazides possibly may have a prognostic effect based on this diuretic response. So our conclusion is that we have shown in a randomized double-blind clinical trial with no industry support that by adding hydrochlorothiazide to usual treatments for patients with acute HFrEF, the mean daily weight loss were 0.7 kilos higher than in placebo group. This was marginally significant. And also that adding thiazide 50 milligrams to usual treatment resulted in a significant 0.4 increase in diuretic effect for every 40 milligrams of IV furosemide used in patients with acute heart failure with reduced ejection fraction. Hydrochlorothiazide was safe and with only mild increase of 0.23 milligrams per deciliter in creatinine. And we believe this is an addition to literature in this field. This is our hospital in Porto Alegre, Brazil, and thank you very much for this opportunity.
Our pleasure, and thanks again for doing this study. So we surely have a couple of questions, but before starting, Dr. Trullàs will have some slides that will compare the two studies, and we're very happy to switch both the microphone and the screen back to you.
Okay, thank you again. We have prepared together with Professor da Silva just a few slides to compare. I think it was important to compare both trials and see the big picture with both trials together. First of all, let's see the context. The CLOROTIC trial was performed in Spain. It was a multi-center trial, including 230 patients. And in the case of the Professor da Silva trial, it was a single center study with a lower sample size. In the case of the CLOROTIC trials, patients were randomized within the first 24 hours. This period was a little bit shorter. In the case of Brazil, it was 18 hours. And there were slight differences in the inclusion criteria. In the case of Brazil trial, patients had at least 2 signs of congestion. It was important. And in the case of CLOROTIC, we did not. It was not mandatory to have a minimum congestion. And in the case of ejection fraction, all values were accepted in the CLOROTIC trial. And in the case of the study from Brazil, it was only accepted patients with reduced ejection fraction. And something similar happened to the kidney function on admission. In the case of the CLOROTIC, as we said before, all values of glomerular filtration rate were accepted. But in the case of Professor da Silva trial, a minimum of 30 milliliters per minute was an inclusion criteria. Finally, the baseline furosemide dose accepted for inclusion was a minimum of 80 milligrams per day in the CLOROTIC trial, maybe a surrogate marker of diuretic resistance, and it was no minimum required to include patients in the Professor da Silva trial. So according to the design, both, as you have seen, are randomized, double-blind, placebo-controlled trial. Both trials tested the same drug, oral hydrochlorothiazide, but in the case of the CLOROTIC, the dosification was adjusted to glomerular filtration rate, and treatment was for 5 days. And in the case of Dr. da Silva trial, the dose was the same for the 3 days, was 50 milligrams every day. And another small differences is that the treatment with furosemide, intravenous furosemide, was at the physician discretion in the case of the Brazil trial. And in the case of the Spanish trial, we provided an algorithm trying to be more homogeneous in this case. Baseline characteristics are also a little bit different. In the case of the Spanish trial, patients were older. And of course, for the inclusion criteria, the values of ejection fraction were higher. And this trial is probably more representative of preserved ejection fraction, which is a complementary thing with the other trial, which is more representative of reduced ejection fraction. Maybe in the Spanish trial, patients had a little bit more of comorbidities in part of this more advanced age. And the values of creatinine at the moment of inclusion were a little bit higher also in the Spanish trial. The baseline doses of furosemide before admission were higher in the CLOROTIC trial. This is normal because it was a mandatory inclusion criteria before admission. The endpoints were also very similar. In both cases, we tested weight loss at 72 hours and weight loss adjusted for furosemide doses. In both cases, we tested dyspnea assessment by the patients and some endpoints of congestion. And we also analyzed length of hospital stay. And the safety endpoints were the similar, renal function and changes in sodium and potassium. And there were only slight differences in other secondary outcomes. In the case of the Spanish trial, we analyzed other metrics of diuretic response and the mortality rehospitalizations in the follow-up period. And in the case of the Brazil trial, the need of vasoactive drug, changes in antidiuretic peptides, thirst scale, and in-hospital mortality were also tested. But the main efficacy and safety endpoints, I think that were really very similar. And the results are also, I think, quite similar because in both trials, patients that receive hydrochlorothiazide experience more weight and more weight loss adjusted to furosemide dosification. And we did not observe changes in dyspnea assessment in any of these trials. And in the case of safety endpoints and worsening renal function, we observed that patients that treated with both diuretics had a higher proportion of worsening renal function. In this case, was only significant in the CLOROTIC trial. But I want to highlight that maybe this clinical relevance is relative because the acute increase in creatinine levels in patients treated with both diuretics was only 0.18 or 0.5 in the two trials. We did not observe disturbances in sodium, which is also very important, which is something that was advised in previous observational studies. And only in the CLOROTIC trial, we did observe more proportion of hypokalemia in comparison with the Brazil trial. They did not have this adverse event. So in conclusion, I think that these two clinical trials are very similar in their design and intervention, and there are some differences in the inclusion criteria and therefore in the baseline characteristics and also some secondary endpoints. I think that the two clinical trials together in only one picture show us that this treatment with oral hydrochlorothiazide is safe and modestly effective in top of loop diuretic therapy for patients with acute heart failure. And probably the trial conducted by Professor da Silva and his colleagues did not reach statistical significance in some endpoints, probably because of the small sample size.
Thank you. Well, this analysis of the comparison of those two trials, they became very very good analysis. Nice to see them both side by side. It's quite a clear way of depicting the differences and the similarities of the two trials.
We didn't talk before the design, didn't we? So it was a sort of coincidence in some endpoints, right?
And it's amazing the similarities in the results, I think. If you look at the thiazides per day, the effect of weight change per day, ours is 0.7 kilos and yours is 0.8.
Yeah.
So it's almost the same. 0.7 versus 0.8 kilos a day. And definitely we were marginally significant just because our study is really a small one.
And this is also quite similar actually to what Dr. Mullins found in ADVER when it comes to the quantitative effect of the diuretic he chose, azetazolamide, both with regard to the clinical efficiency and also to the overall results. It's quite similar. So surely you have not been aware of the ADVER trial because it was published after you did your studies. But now that we have these data from ADVER, would you consider in at least some patients to use azetazolamide rather than thiazides, or to combine the two of them?
Luis, you go first.
Well, that's the obligatory question. This is we discuss this every day in our rounds when we are seeing patients. In our scenario, there is much more. People are much more used to use hydrochlorothiazide as a second diuretic. And it's very hard to change that because people are just used to that. And myself, I have tried to many times to prefer acetazolamide before thiazides because I'm considering the size of the studies. And despite my study being the smallest, I would say that I have I realize that we have to follow larger study first and smaller studies after. So, but this is my opinion. My colleagues, most of my colleagues in our region and in our country, they would rather use hydrochlorothiazide first. And the other reason it's a little bit tough to use acetazolamide is that we do not have the IV formulation that Dr. Mullins have tried in his trial. We only have oral. And actually, we don't really know what would happen with the oral formulation. And this is actually a matter of a new study, actually, to try and test even side by side thiazides and acetazolamide in an oral formulation.
And now I may ask the stupid question: SGLT2 inhibitors, how will they affect your results? You think? We now have MPulse, HF, and all the other trials now coming out. Would you have designed it differently, your study?
I think that we don't have to be worried about that because the site of action is quite different. And SGLT2 inhibitors, I think that we are not going to use them as real diuretic therapy just to improve prognosis. Maybe they have a slight effect on diuresis, but they won't have enough potency to be diuretic treatment. I would be more concerned if they would be useful in the case you use acetazolamide, because they can maybe compete in the same part of the kidney. But in the case of thiazides, I don't think it won't interfere in the results, but of course it would be desired to perform again a clinical trial using SGLT2 inhibitors, but considering the high effort of conducting this kind of trials, it would be difficult, at least in the next years.
I think maybe one thing would be nice with SGLT2s theoretically I see them as a little bit a kind of airbag against a worsening renal function. So because with the thiazides, maybe you can deduce it from your results, you decrease the autoregulatory capacity of the kidney, even if they're together on board with RAS inhibitors. So with an SGLT2, at least you can afford maybe more easily, without the danger of going into an AKI, an aggressive decongestion, theoretically.
And I guess more and more people will come to hospital in the upcoming years who are already on SGLT2 inhibitors. So probably in a year or two, we won't have to discuss too often whether first to start with the SGLT2 inhibitors or with the thiazides. So if a patient comes today to your hospital in Porto Alegre or in Spain with decompensated heart failure, you would start with a thiazide and start the SGLT2 inhibitor if the patient is not yet on that drug some days later? Or how would you proceed today, tomorrow?
Well, we use IV furosemide and SGLT2 inhibitors in everyone in the first day, in the time 0. But the thiazides will not come in the first day. We'll wait until we see the diuretic response. If the patients go really well, they will not receive any thiazides. But the patients start to drag and to not have the same follow-up as we expect. They are not losing much weight as we expect. Then we associate thiazides maybe in the 2nd or 3rd day. And then definitely we see an increment in diuresis and weight loss after we use thiazides. But many times the patients will respond basically only on Lasix and only in an SGLT2 we basically consider as a standard of care, and every patient will receive it as a prognostic impacting drug.
And do you also block the ACE inhibitor or the angiotensin II receptor blocker when there is an initial increase? Because many patients come with a slightly increased creatinine. And especially in your study, in the CLOROTIC study, Professor Trullàs, you had HFpEF patients. And there are very good data that the increase in the creatinine under the ACE inhibition has a worse prognosis. So did you, in your study, in both of you, also on a granular information, stop the RAS or decrease it and then increase the diuretic dose?
Well, when we conducted the CLOROTIC trial, we did not have ARNIs or we did not have SGLT2 inhibitors, and so we cannot have data of what could have happened. But I think in our clinical practice or experience, if the patient is already receiving these treatments and is admitted due to the decompensation, we try to maintain both treatments despite the kidney function on admission. It's a different thing if you want to start them during the hospitalization, but if the patient is treated chronically, we probably recommend to maintain, if at least if there is a main or a contradiction or adverse event. So I would recommend to maintain, but this is only based main on experience. We don't have the data. I would like to add that before the question, I completely agree with Professor da Silva that we have to give 24 hours before deciding if you add a second diuretic. But we normally base this decision on the baseline treatment that the patient was doing at home. So patients that are receiving 2 or 3 pills of furosemide at home, some of them will expect resistance despite you give the furosemide intravenous. In some patients, it's just a problem of absorption. They don't have really a real diuretic resistance and they are going to respond. But if after 24 hours there is no response and the patient is taking 80, 120 milligrams per day, we start early with thiazides.
Mm-hmm. Maybe we are also interested in when your patients leave the hospital, what about the thiazide? Is it a long-term therapy or a transient therapy?
it should not be a long-term therapy because of safety concerns. So this must be the message. So this is just a treatment for 3 or 5 days until you achieve this congestion. But I also would say personally that in some selected cases that patients tolerate well the thiazide without kidney or electrolyte disturbances, sometimes in the outpatient setting, we maintain the thiazide. But in this case, patients must be strictly follow up in the heart failure units or day hospital to straight follow up kidney function and sodium or potassium. But this is for just very individual selected cases. The message, I don't know if Professor da Silva agrees, it should be just for the acute phase.
And do they also have a drinking protocol so that they are not allowed to drink more than 1.5 liters, for example, or you don't interfere with that? Because we as nephrologists have to get out with all this drinking that the kidneys get better, and then they drink 3-4 liters per day and always have decompensation. I don't know whether you handle that.
We are not really very strict with that. So we leave it a little bit to the patient. So because sometimes if you say to a patient that you have to drink more liquids, then maybe it's contradictory of what you're trying to do. So maybe we leave it to the patient. We are not that strict. We're not strict during the trial. So we leave it just to the patient. And we also are do the same recommendation in our clinical practice.
Okay.
This brings us to the second lifestyle intervention that we discussed with Dr. da Silva time and again, salt intake. So what are your recommendations, both in the study and surely in clinical practice, when it comes to salt intake? Do you still advocate salt restriction?
Well, very briefly, I will answer almost the same for the water restriction. We were not, we did not put it in the protocol. So every center did their clinical practice, but I believe that all our colleagues are not very strict with salt restriction, because the data we have is that being so restrictive is not really useful, and patients then are not so happy with if you're very strict with salt restriction. So we were only slightly restrictive, but in the trial, it was not in the protocol. So every center did what they did in their clinical practice.
Yeah, actually, I agree with everything that you have said, considering diuretics and salt. And this particular point, we have done a small clinical trial as well. It's published at JAMA Internal Medicine, and we could manage to test salt and water intake in patients with acute heart failure. And we have seen that what we gain is patients with more thirst than anything else. So patients who have the same congestion, the same weight by 3 or 7 days, and the patients who are restricted will complain of thirst much more than the other group. And so it's basically a neutral trial to restrict. And we have made a very aggressive restriction of 800 milligrams a day of salt and 800 ml of water, liquid per day. So this is a neutral study compared with free meal, ad libitum food and an ad libitum water. So it's which made us think that we became much more flexible after that result in our center, and then we live in the whole world, because nowadays we have seen the study of Dr. Tang at the Heart Failure Society of America meeting, performing a clinical trial of giving capsules of salt to patients with acute heart failure compared with placebo. And he could show that patients who received 2 grams of sodium chloride 3 times a day orally had less renal dysfunction than patients who received placebo. So this is incredible. Like we are testing if we should restrict or not. And our American colleague is testing to give sodium to those patients. And that's the way the things are going.
Maybe potassium chloride would be even better. May I ask you, on the long run, will you perform outcome data on the long run, or subsequently follow your patients, or are you aware whether this more or less aggressive decongestion strategy has a longer term impact, so reducing the frequent flyers or even have an impact on mortality?
Well, I always say that congestion is a toxic thing in heart failure. So we should manage to keep our patients euvolemic, whatever it takes. But the way we do it, I'm sure everyone does that in a different way. But it's important to think that we should not leave our patients congested. And there is amazing number of ways of doing that in devices and lifestyle and drugs. And maybe what really matters is to keep them dry.
Completely agree.
So we touched upon SGLT2 inhibitors, surely. We touched upon acetazolamide. Do you still see a place for tolvaptan in acute decompensated heart failure?
You have that available?
We would have, yeah.
But there's now a biosimilar coming out. Maybe also in Germany in September we have it.
Okay.
Yeah, so it's more affordable now.
I would love to have it at my shelf, but we don't.
We have it. It's very expensive, surely, for outpatients. So we started sometimes in patients with severe hyponatremia, but it's really difficult to get funding once the patients leave the hospital.
Yeah.
We have this Brussels champagne as a cheap alternative. You know, this urea with with that, yeah.
The same problem in Spain. It's very difficult, it's very expensive, and you have lots of problems when you want to prescribe. But I think that there's a window of patients probably with severe hyponatremia they could fit. But I've never been able to test it in a single one because of restrictions.
It will change now because the patent is now gone. And now, you can get it as a generic.
So you would use it more often, Markus?
I use it very often, but more we are a hyponatremia center, so therefore we use it together with our oncology colleagues and idiopathic, but I didn't use it in heart failure. We have this heart failure trial, which was neutral. It is a surprisingly nice substance with regards to adverse effects. It has nearly no adverse effects. Also, you get out a tremendous bunch of water, of free water. Maybe there's you in the right way, there is a potential for that. Yeah.
Well, we have participated in the Everest trial of tolvaptan myself, and actually, I would say it's not a double-blind trial, because the patients who received the drug, they would pee like 15 liters a day. It's just crazy. I have a young patient, 17 years old with cardiomyopathy. He lost like 15 kilos in a day. And his potassium was normal. It's unbelievable. But unfortunately, you don't have it available, and it's too bad that the study came out as a mortality trial. And the mortality was neutral. But I do believe this drug has a positive effect if it's well used in a correct setting.
Yeah, absolutely, and maybe also in combination, because you get a nice nearly 100% free water clearance, so without any sodium loss. Maybe if you combine it with a thiazide or what else, or an SGLT2, you get maybe a completely differential decongestion. Obviously, the quality of decongestion also matters, as we see it with SGLT2 inhibitors, when you get rid of interstitial volume, even it's only 0.5 or 1 liter.
But we have no data on that combination, do we?
No. Therefore, I think we shouldn't bury it, the tolvaptan, with these studies that you did, and with SGLT2, maybe it has a distinct place there. Yeah.
I believe this drug has to be retested, particularly in the acute heart failure setting.
Yes.
And looking at secondary outcomes, not mortality.
Yeah.
And even quality of life could be important for those patients.
Yes.
It also should be tested in patients with more advanced renal insufficiency, because I think the average trial patients had not really advanced chronic kidney disease, if I don't remember properly. But I mean, I don't know if tolvaptan would work in patients with more advanced diuretic resistance or kidney function impairment. I'm not sure.
Yeah, we use it in adult polycystic kidney disease, also with impaired kidney function, so it works.
It works.
You can, you have to dose titrate it, but it really works good, yeah.
And in fact, all these trials, including our trials, they are all outdated now, because we should redo all of them again because of SGLT2 inhibitors.
That's a fast field.
It's not the same scenario anymore.
Maybe one additional word to our young colleagues when it comes to increase in creatinine, which was observed sometimes in both of your studies. This does not have any adverse prognostic implication. We have seen time and again in a couple of trials that people who have a creatinine increase during decongestion have at least an outcome as good as patients with stable creatinine. Sometimes it's even better in those patients. I have one final simple question actually from my part. So why did you choose hydrochlorothiazide and none of the other thiazides? Was there any idea behind it, or just because it's the most frequently used thiazide?
Well, I go first. In my case, the reason is because it's the mostly available and used drug in our center and in our country. And it was already used before we did the trial, but without having any data. And that's the only reason.
In our case, I would say that probably it was a little bit of chance, because in Spain, I think that I don't have the data, but 50-50% of physicians use hydrochlorothiazide, but the other ones use a lot of chlortalidone, which is very similar to metolazone. It's a thiazide diuretic mainly used in the United States. So we were discussing, and maybe probably by chance, we decided hydrochlorothiazide, in part because we read, when we were designing the trial, a very nice review paper in the New England Journal of Medicine. I think it was published by a pharmacologist, if I don't remember. And in this paper, they provided this algorithm of dosification stratified according to glomerular filtration rate. And we did not have the alternative for chlortalidone. That's why we use it. But I think, I don't know, maybe I would like to know your opinion. Part of these good results is that because we chose hydrochlorothiazide, I'm not sure if using chlortalidone or metolazone, we would have seen the same results. In terms of efficacy, I would guess that yes, but I'm not sure in terms of safety because of the long-term effects, because of the different pharmacokinetic and pharmacodynamic properties. So I'm not sure if using chlortalidone would have been as safe as using hydrochlorothiazide, and I'm also like to hear your expert opinion.
Well, that's actually what we saw in the comparison between the two drugs in hypertension. Surely quite different field of medicine, but there was no effect on cardiac clinical endpoints, but there were more side effects with a longer acting thiazide. So the same may surely also apply to heart failure.
Hydrochlorothiazides in Spain or Brazil also part of the usual antihypertensives? Because in Austria it's everywhere. Okay.
They are widely used for hypertension. Yeah.
Okay.
I would say for hypertension, the most widely used here is chlorthalidone. But when we use an addition in heart failure patients, we used hydrochlorothiazide mostly. That's basically by practice. And that's possibly why we have decided to test what has been already been done. And then we had that result.
Markus, any remaining questions?
No, it was extremely interesting.
So
I'd like to make a final question to Dr. Trullàs. I was, by watching the comparison of the two trials, it came to my mind that actually your patients are older and sicker, apparently, and with mainly preserved ejection fraction. And you have seen more kidney function failure, kidney failure than I have seen. And congestion also was not a prerequisite to include your patients. So don't you think maybe you had less congested patients than I had, and maybe because of that you had more kidney failure?
That probably yes, and this is also an acknowledged limitation of the trial, that we didn't have a minimum pre-specified congestion on admission before randomization, and that's, I probably agree with that. Can be the explanation of that, yeah.
Okay.
So thanks a lot. Thanks for this academic hour, but surely thank you for doing these studies 60 years after these drugs entered the market. It's funny to see how long sometimes it apparently takes to get the evidence, but now we have the evidence thanks to the two trials from Spain and from Brazil. So thanks again, and hopefully we'll meet one day again here at Markus at Home. Have a nice evening in Spain, nice afternoon in Brazil.
Thank you very much.
Thank you.
See you soon.